Hello, everyone. This is Dr. Yonit Arthur. I'm an audiologist and strength coach. You're on my channel, The Steady Coach. And today I have an amazing, interesting guest for you guys. So my guest today is David Gauguin. David is a licensed mental health counselor who also works with people who have chronic conditions like chronic pain, fibromyalgia, chronic fatigue syndrome, and he is also a certified clinical trauma specialist. So David has his master's of education in mental health counseling, which he got from Bridgewater State College in Massachusetts. And in addition to his other illustrious credentials here, he is also certified in pain reprocessing therapy, which is a type of therapy that has some very awesome, brand new cutting edge research behind it. That recently, I'll link to the article below, was shown to be much more effective at managing chronic pain than the conventional treatment that we've been accustomed to thus far. So David's here today, not just to share his expertise with you guys, but also to share his own personal story of recovery from all sorts of chronic conditions. Mm-hmm. So David, thank you so much for joining me today.
You're welcome, Yonit. It's a pleasure to be here, and thank you for having me.
Yes, well, we're so excited to have you here because one of the things that I have been shouting about on my channel a lot is that chronic dizziness isn't getting as much airtime as chronic pain. Mm-hmm. But you and I have talked before, and we've talked about how similar the mechanisms are between mm-hmm. chronic pain and chronic dizziness. And I think many of the stories you're going to share today and some of the expertise that you're going to share today are going to be just as applicable to those with chronic dizziness as they are to chronic pain.
Mm-hmm.
Yeah. So
absolutely.
How would you feel about starting this off by sharing a little bit more about yourself and your own story? Because you have quite a story.
Yes. I don't know whether to say fortunately or unfortunately.
Right?
Yes, I do.
Yeah.
Yeah. So I have I've been dealing with some form of chronic, either chronic pain condition or other chronic health issues that I have come to believe are mind-body conditions. The first one started when I was a teenager. When I was about 15 years old, I started having chronic back pain. And, there was no really good reason for it because I was otherwise a very healthy, teenager. I was very active. I played a lot of sports. There was no injury, and I just started having back pain. And so I had chronic back pain for close to 40 years, which is a long time.
Yeah.
And, over those 40 years, I also had chronic sciatic pain as well. That kind of went along with the back pain. And over the course of those 40 years, of course, I saw, many different doctors, and they all had their different opinions and diagnoses. I had back surgery when I was 25 years old for a ruptured disc. But, I learned much later in life that having a ruptured disc doesn't necessarily cause pain or needs surgery to correct. I didn't know that then, but I learned it later.
And actually, coming back to what you were saying a few minutes ago, that you've come to believe that these conditions are mind-body. Would you mind sharing what you mean when you say mind-body?
Sure. That the cause of the pain or the other, whatever chronic condition is not structural. It's not organic. It's not due to an injury or disease. It's the mind. Mm-hmm. The mind is actually creating the pain and causing these other conditions. So
thank you.
You're welcome. So, so like I said, I had the chronic back pain for a long time, and I just, learned to live with it. I had a doctor tell me early on that he thought I was born with abnormally weak back muscles. And that's why I had chronic back pain. And, he's a doctor, so I believed him. And yeah, so I just believed that I had, I was born with a bad back, and I just had to learn how to live with it, and, go to physical therapy off and on, when it would flare up. And I had to be very careful about, my posture and, how I would sit, and make sure that I had, good back support, and, all kinds of different ways of accommodating that. So, and then about in 2009, so it was about 11, 12 years ago, I started having pain in my right foot, in the back, the heel of my right foot. And over the next 2 to 3 years, the pain in my feet got progressively worse, and it actually kind of spread. Like I said, it started kind of localized in the heel, and then it spread throughout the bottom of the right foot, and then eventually to the left foot. And again, I didn't know then, but that's kind of a common feature or characteristic of mind-body pain, is that it's, kind of symmetrical on both sides of the body. So again, if it's structural, it's not going to jump from one side of the body to the other. So anyway, so over the next 2 to 3 years, I saw like 6 different foot specialists, podiatrists, orthopedic surgeons. Each one, again, had their own diagnosis, treatment. Obviously, nothing that they prescribed worked or helped. Because if it did, I wouldn't be here.
Yeah.
Telling you, the story.
Yeah. Yeah. So you tried all sorts of medical treatments. You sought help from many physicians and other specialists, and they all had different opinions on what was wrong, right? You got a whole bunch of different opinions. And this is a story I'm sure that many of you guys can relate to. I would say the average person I see in my clinic has seen at least 5 physicians by the time they get to me, but that's sometimes even on the low end. I've seen people who have seen 20 plus physicians.
Yeah, I think over the span of about 3 years, from 2009 to about 2012, I saw, I think, about 15 different doctors.
Yeah.
So eventually I was diagnosed with what they call idiopathic peripheral neuropathy. And idiopathic means we don't know what's causing it. So again, I didn't know this then, but I know now that that's another common characteristic of mind-body pain, is that doctors are not able to identify the cause. So another term that's used to describe mind-body syndrome is medically unexplained symptoms, or MUS. So I had a lot of medically unexplained symptoms, and that was not responding to the conventional treatment. So they referred me to pain management. And so that's where I went, and I went to 2 different pain management clinics. And the first one, what ended up happening is, because all of the foot specialists couldn't find out what was causing the pain in my feet, because I had a history of back pain and, back surgery, then they thought, well, maybe something in the spine is causing the pain in the feet. So then I started seeing, back specialists and neurosurgeons and all of that. And we were kind of going down that rabbit hole.
Mm-hmm.
And so we were focusing on the back. And I think over the course of a year, I got 10 epidural steroid injections in my, under anesthesia in a year. And they say, I remember them saying that the shot should last 9 to 12 months in terms of relieving the pain. And it didn't. And I was back after 2 months and they would do it again. and so, yeah, I did that. And then, again, it didn't result. So, after that didn't help, then it was the spinal cord stimulator.
Mm-hmm.
They wanted to try that. So I had the trial for that. And, I had it in for 24 hours and to be honest with you, I wanted it more to help, to see if it would help with my feet pain, because at the time the pain in my feet was the primary, issue, and the worst. And so I wanted to try it to see if it would help with the feet pain, and it didn't really. And so after 24 hours, I said, take it out. So they took it out. Then they have another thing called, what's it called? It's like an implant. It's like a continuous epidural implant where there's the whatever medication they use in the epidural, it's like released slowly, or you have like you can control how much to release it into your system. So I did that trial and it didn't work either. So after that, the pain management doctor said, we have nothing else to offer you. And I also tried all of the pain medications that they had to offer, tried all those, and nothing seemed to help. Or they might help a little bit in the beginning, but then I would need to take more and more, and they became less effective. So I ran out of options with the pain management doctor, and so that was it. There was nowhere else to go.
And this is what happens with dizziness. In many cases too, people see physical therapists over and over. They see, I don't know if you see this with your clients too, but mine will just keep seeking more and more opinions, trying to get some doctor to say, oh, this is actually going to fix it. But nothing does. Nothing works.
Yeah. Again, I think that's very common. And I went through that myself because I didn't know about Mindbody. I like, I'm sure, all of your viewers and most people are brought up to believe that if you have pain, that means there's something wrong with your body.
Right.
And that the people to help are medical MDs, doctors.
Yeah.
And again, doctors, I'm not, I'm not criticizing doctors. I mean, they're trained to view the body in a certain way, and they're looking for disease. And the best technology that we have to see inside the body, that's what they're looking at. And if somebody goes in and says, it hurts here, and they do a CAT scan, MRI, an X-ray, and they see something, then they're going to conclude that that's what's causing it. You're telling me you have pain there, and I'm seeing this, so that's what's causing your pain. That's how they're trained.
This is an important point, because I have clients and people who watch my channel who have been diagnosed with some kind of thing that originally set off the dizziness. In the case of dizziness, frequently it's something like a viral infection of the ear, neuritis, or migraines, which is a whole Pandora's box that we aren't going to open right now. But there's some kind of medical explanation for the origin sometimes of the symptoms. But what then happens is once those symptoms become chronic, it's no longer explainable by that original medical diagnosis. So,
and yes, and it's possible that the original medical diagnosis was incorrect.
correct. Absolutely. Yes.
So there's that possibility, but even if there was some, legitimate injury or some legitimate, virus, or, I'm not as familiar with the dizziness
Sure.
side of things, but,
Sure.
A medical doctor who's very big in this mind-body community, his name is Dr. Howard Schubiner. He says that all injuries heal, and that scars don't cause pain. So, it is for a lot of people, they may have had an injury and they had pain because of the injury, but injuries heal. And if the pain is persisting longer than what's considered the normal, healing process, which is, again, depending on the injury, but a couple of weeks to a couple of months, if you're still having pain beyond that, it's most likely not because of the injury.
Correct. And the same is true for dizziness. The brain will adapt. The brain adapts to changes in the vestibular system. Even if an ear was taken out by a virus, the brain adapts. 6 weeks in, most people are feeling a whole lot better. And if they're not, or if they have new symptoms, which we started to touch on, if the symptoms do weird things, weird illogical things, then we're not looking at a condition that has a biological cause anymore. It's no longer a biological cause. We need to start looking at the psychosocial factors.
Right. And again, like you said before, or like we talked about a minute ago, is I also had many, many different medical diagnoses by medical professionals. Yet they couldn't treat the pain.
That's a really good point. And I'm going to emphasize this. I'm going to just point out what you said. You had legitimate medical diagnoses by great professionals who
meant well.
Yep. Many of my viewers have diagnoses. They have diagnoses, but the diagnoses sometimes don't correspond to what they're experiencing, or the diagnoses are things like idiopathic pain syndrome, or or peripheral neuropathy. In the case of chronic dizziness, it's often persistent perceptual postural disorder, or PPPD, or it's vestibular migraine. Again, we can't explain it, so we're going to give you this diagnostic name.
Yeah. Well, fibromyalgia also is another condition that the diagnosis is just describing the symptoms.
Yeah, just describing the symptoms. So,
well, I just wanted to point out, it's very interesting. What's the PPD?
Triple PD, yeah. So persistent postural perceptual disorder. So PPPD, which is basically just a term for chronic dizziness with no medical explanation.
Well, what I find interesting is that another term for mind-body condition,
psychophysiological disorder,
is psychophysiologic disorder, which is PPD.
Yeah. Yes, we think all we have to do is take away one of the P's, and it'll make complete sense, right?
Right.
Yeah, and that's a term.
Interesting.
I use that term on my channel a lot here. So if you've been a regular viewer, you've heard me talk about psychophysiologic disorders, but it's a mouthful, and it's so close to triple PD that I don't always use the acronym since they could be easily confused. But if kind of thinking more about these symptoms, so I also want to mention, you and I, when we talked the last time, you mentioned also that you had a bout of dizziness as well in there. So can you tell us more about what that was like?
Yeah, sure. So, but before I do, I just wanted to say that I also was diagnosed with fibromyalgia.
Oh, yep.
Yeah, can't forget about that.
Yeah, can't forget that. Yep.
So this was about 2012, and again, this is after 3 years of going to all the doctors and tests and treatments and pain management, and nothing was. And then I started developing new symptoms, new pain symptoms, and like they call them trigger points or pressure points in your neck and your shoulders and your back. So I was getting that, and then I started getting chronic headaches, like daily headaches. I wouldn't say they were migraines, but maybe just kind of stress, tension type headaches. But every day, and then I went to see doctors for that, and then I don't remember exactly when the bout of dizziness happened, but it was some time during all of that. And this is 10 years ago, but from what I remember, I think I just kind of turned my head quickly, and all of a sudden the room just spun, and it didn't last. I mean, it lasted a second or two, but then the effects of that lasted, like just kind of feeling like a mild headache or maybe a little nauseous. And then that would last for a few hours or a day. And anyway, I went to see an audiologist, and I'm trying to remember the diagnosis. You would probably know, but
so they actually gave you a diagnosis? Okay.
Yeah.
Was it BPPV or benign paroxysmal positional vertigo, or no, Meniere's disease?
No.
Vestibular migraine? Oh, we can run the whole gamut. But
I think I had some. Well, actually, she sent me for some tests first, and they blow it
air in your ears.
Yep. In your ears, yep.
So you'd maybe hypofunction, like they thought you had a weakness in your ears? No. So in any case, they couldn't explain it. There was no explanation really given for it.
Well, I just remember the word vestibular being in there somewhere. That's all I remember.
Okay.
And then she referred me to physical therapy. So I went to physical therapy, and they gave me some exercises, and I did them because I am a very good patient. Pain is a very big motivator for me. So if you tell me that if I do this, my pain will go away, I'm going to do it. So I did the exercises, and it actually helped, and the dizziness went away, and I haven't had an issue with it since. So it was just that one time. And like I said, the physical therapy helped. So,
which, as we know, doesn't necessarily rule out mind-body syndrome. And that's something people, I think, also need to understand, that just having the attention of a caring professional can soothe the fear that is sometimes the primary driver behind these kinds of disorders.
Yeah, 100%. And when we talk about what to look for in a practitioner or provider, I'll talk a little bit more about that. But there is absolutely something about what you just said about having a supportive, caring professional, that you trust. And there's something called positive expectancy. And if you are with an expert, somebody who's trained, and you trust them, and they tell you, if you do this, you're going to get better, you're going to believe it. And again, the mind is so powerful that if we believe something is going to help, it will help.
Yeah.
And the opposite is true. If we believe that something is not going to help or work, it won't. It probably won't.
Right. The nocebo effect.
Nocebo.
Yeah. The nocebo. So you had a lot of diagnoses. Your symptoms were just kind of steadily getting worse. Nothing was helping.
Right.
So what was your daily life like at this point when the symptoms reached their peak? What was your daily routine? What was daily life like?
Not great. to be honest with you. I actually was not, I had to take time off of work. I think 2 or 3 months at a time, I would need to take time off of work.
And just to be clear here, so our viewers understand, you weren't actually working as a counselor at this time.
Correct.
Right.
Correct.
But
Yeah.
so it was a more of an office.
Yeah, I was working as a case manager, kind of human services type work. I was very fortunate in that I was able to work from home. So, but even being able to work from home, sometimes I couldn't do it. But I do remember when I was working during this time, I would have to change positions frequently, and so I couldn't sit for too long. I would I would put a mattress down on the floor in my living room, and put my laptop on the mattress, and I would lay on the mattress on my stomach and prop myself up on my elbows so that I could type on my laptop. And after a while, of course, my neck and upper back started hurting.
Of course.
So I couldn't do that for too long. And then, I tried so many different, different type chairs, like recliners and zero gravity chairs. And, I had made this like arm thing that with like a flat board that I could put my laptop on, and I would fully recline in the recliner and have this thing, and so I could work on my.
You were doing like gymnastics in order to type on your laptop.
Absolutely. And then even when I was sitting in a chair, I would have to put my feet up on a stool or ottoman thing. I couldn't put my feet on the floor. So that's what it was like when I was working. And then when I wasn't working, it was, just laying on the couch. And, if I had headaches, and I'd close the curtains and be in the dark, and just trying to do anything that would bring some relief.
Yeah.
Taking a hot shower or a hot bath, or,
So just a lot of dark thoughts and a lot of darkness.
Yeah. Thank you for asking that, because we're human beings, and when things are bad, and we have chronic pain, it typically causes a lot of emotional distress. And so I started to, have an increase in anxiety and depression, again, as a response to what I was going through. And that's normal.
Understandable.
It's perfectly understandable. So, yeah, it was pretty bad. And there were times when I, wondered if I could, how long I could continue living with being in pain. I mean, literally from head to toe. In fact, I even told my doctor one day, I says, I'm running out of body parts to lean on, because no matter what I lean on, it hurts. So, you just start thinking of ways to stop the pain. And so I had definitely had some of those thoughts. And again, it's not that I didn't want to live. I did. I just wanted the pain to end. And again, that's unfortunately a very common experience for people with chronic pain
and chronic dizziness.
And chronic dizziness as well.
Yeah. So, I mean, and now obviously we're sitting here talking about it. You're sitting on a chair, looking relatively comfortable. So at some point there was some turning point where things started to change. So would you mind sharing some of, I know for you there was more than one, so if you wouldn't mind sharing those turning points with us.
Sure, absolutely. So September 2015. That was the first turning point for me.
Yeah. Not that we've earmarked it or anything, right?
No, right. Yeah, it's not that important. So, yeah, so leading up to that point, so like I said, I was diagnosed with fibromyalgia in 2012. I found a doctor, I'm in the Tampa area. I found a doctor who said they could, treat or heal fibromyalgia. And I went to see him. I spent $5,000. And that's another thing. I spent over the years, spent thousands and thousands of dollars with everything, all the doctors and treatments and different, like I said, recliners and different mattresses and all of that stuff. And then stuff like this. And again, he was, a really nice guy. I really liked him. I believed him. He had good intentions. And so he did some blood tests. I had a whole bunch of food sensitivities. And he said, you need to cut out all these foods. And I did. And I felt better for a while, but then it came back. And again, I believe looking back, that was probably that placebo and that positive expectancy. I believed what he was saying. And so then, it slowly came back, and we tried, a few other things, and it didn't work. And so after a year or two with him, I just kind of moved on. And so for the next few years, I've been to every doctor everywhere. There was nowhere else for me to go. So I just had to learn to live with it.
And so September 2015 was what? What happened then?
So I had been on this strict diet for a number of years. I was going to physical therapy, massage therapy, chiropractor, regularly, exercising, stretching. I was doing everything, trying to have a healthy lifestyle. Doing everything that I could, and I was still feeling miserable, still in pain. I'm like, there's something wrong with this. This is just not making sense. So I went back online and started looking around, and I came across this Dr. John Sarno, and he was a doctor up in New York. He was a doctor up in New York, and he had written some books. One is called Healing Back Pain. Another one's called The Mindbody Prescription. And, there were a couple of celebrity clients who said that they had debilitating back pain. They went to see him and they were cured. And, of course, I'm like, this sounds a little too good to be true. But I'm like, well,
what else do I have to
lose? I tried everything else. So, it was like a $15 book on Amazon. So what have I got to lose? So I ordered the book, actually the two of them. And I got the book and I was devouring it. And while I was reading, I think the Healing Back Pain, I had been having this pain up in my mid back for months. And again, getting all the treatments, it's not going away. While I was reading that book, the pain went away and it hasn't come back. And it's, and I'm like, oh my God, like there's something to this. And, while I was reading the book, it's like I saw myself in the book. I felt like the book was written about me. It was like that experience. So, again, because I think for me, and I think this is kind of what helped me, was because I had already done everything that I had done up to that point. I was open to the possibility that what he was saying, that the brain was causing my pain. I was open to it because I was desperate. And I think for some people, they need to go through that process. And, legitimately, people do
You want to make sure.
Yeah, you do need to
Yeah.
rule out a medical structural cause. You do need to do that. And I did that, like, in spades. So anyway, so for me, I think that's what helped me to accept it right away, was because I had already been through all that other stuff. And it made sense to me. What he was saying made sense. And, he was talking about, things that could contribute to developing this kind of condition, things like trauma, childhood trauma, just the stress of everyday life, certain what he calls personality traits, which, as a mental health professional, I have learned are what's called self-defense behaviors. But he's a medical doctor. He's not a mental health professional. So, but things like perfectionism, people pleasing, being very hard on yourself, like kind of that inner critic, self-critic, or that inner bully. Dr. Sarno talked about how those can contribute to developing this kind of chronic pain, repressed emotions, especially anger and rage. So the term that he came up with was TMS, tension myositis syndrome. But again, that's now evolved to PPD, and now it's neural circuit, neuroplastic pain. But they're all talking about the same thing.
Yes, and on this channel, I've been referring to chronic dizziness as neural circuit dizziness.
Yep.
Yes,
that's Dr. Schubiner refers to it as neural circuit.
Yeah. So you read this book, all the light bulbs went off. Well, went on, I suppose. Went on.
Yeah.
And it's interesting because I hear from people on my channel all the time. I get comments, "Oh my gosh, that's me. You're talking directly about me," right? So it's really, I think that's a really important point, that we have to really be ready to recognize ourselves in this, see ourselves reflected in these descriptions.
Absolutely. And again, Dr. Sarno said, and he worked with thousands of patients over many years, and there are some people that are just not able to accept it or believe it, and that's too bad. But if somebody isn't open to this and isn't able to accept it, then this approach is not going to help them.
Yes.
And when I get a potential client call me, that's part of my screening process. Because if you're not open to this, then my approach is probably not going to help you, and I don't want you to waste your time and your money. So
yeah, I've had to start doing, I do the same as well now. And that's why I have a free course I offer for people with chronic dizziness. And basically the requirement now when someone wants to work with me is, I want you to have either read one of these books by Dr. Sarno, Dr. Schubiner, Dr. Schechter, or have done the course. And we don't have to be fully invested. I'm sure you also had doubts along the way. Like, you had moments where you're just like, wait, there's no way this could actually be it. That's part of the process.
Absolutely. Yes.
But what if? There has to be a what if moment where you're like, it could be.
Yeah. And again, that's why I describe it as being open. But I'm not saying you have to be 100, have no doubt whatsoever and be 100% sure, but just open to this possibility. And then if you're open to it, then we can explore it, and we can look at, we can do an assessment and look at, your symptoms and when it started and what was going on. And again, there are a number of common characteristics for this kind of pain. And so we go through those things. And if you're saying yes to a lot of these kind of common characteristics, well, then, chances are
that's what you got.
Yeah. And then we go about looking at exceptions. Because with this kind of pain, I know it was absolutely true for me, there were times when I didn't have any pain at all, and realizing that if it's structural, organic, it doesn't come and go. And yeah. So, you begin looking at the evidence to support a mind-body, quote unquote, diagnosis versus a structural.
Yes. And I'm going to link to a video in the description here, guys. I have a video on this. I can't remember how many criteria. It's somewhere between 15 and 19, a checklist that you could check off for yourself to see if you meet some of these criteria.
Yep. Well, also the PPDA, the Psychophysiologic Disorder Association, has a website, and they also have kind of an assessment, questions. Yes, self-assessment.
Yep. So I'll link to that. I'll link to that below as well.
Sure.
Yeah. So okay, so
I had that light bulb moment.
The light bulb moment, and there was an immediate resolution to some of your symptoms.
Yes. And
then what happened next?
Okay, so there was I had immediate relief of some of the symptoms, and then some of the other symptoms took a little bit longer. It was more gradual, but over, I'd say, the next 2 to 4 months, the most, if not all, of my chronic back pain and sciatic pain was completely gone. And I've been having constant sciatic pain for 5 years leading up to that. And also most, if not all, of the fibromyalgia pain was gone. Headaches were gone. The pain in my feet, the idiopathic peripheral neuropathy, did get significantly better, but never went away completely. So I still have some of that. But again, I forgot to mention this, but when I was at my worst, I couldn't be on my feet for more than 10 or 15 minutes because they would just be burning like crazy. So I actually went out and bought myself a wheelchair, and I was in, my late 40s, early 50s, and again, otherwise perfectly healthy. And I had to use a wheelchair. So that was 10 years ago. And I was also, thinking of, was very close to going on disability, like permanent disability. So, so again, not 100%, but so much better than it was before. And, I want to say to your viewers that everyone is unique and everyone is different in how they respond. And so when people work with me, I tell them that I cannot predict or guarantee what's going to happen with your symptoms. But what I do believe that I'm very confident that I'm able to help people with is to help them to reduce the distress. I refer to it as peeling away the distress, because when people have chronic pain, there's the chronic pain, but then there's the distress around the pain or the dizziness. And so in my work, I focus on how do we peel away the distress.
Yes,
and
but this isn't right. And I want to, it sounds like you're about to segue into what I was going to ask about, but it's not the same as acceptance and commitment type approaches. It's not. There is a further step after that point.
Absolutely. I haven't been trained in acceptance and commitment therapy, but from what I've heard and read, that is kind of the more traditional approach to working with folks with chronic pain. And my approach does involve some acceptance.
Sure.
There has to be, because again, I can't predict or guarantee what's going to happen with your symptoms. My hope is that when you peel away the distress, that at the very least, you have better quality of life, regardless of what happens with your symptoms. But I also believe too, and we haven't really talked about this, but the trauma piece and how trauma affects us physiologically in our nervous system, our autonomic nervous system. I do believe that helping people to learn about that and learn how to regulate their autonomic nervous system can lead to a diminishing of the physical symptoms. But I can't predict and I can't guarantee.
And that's very diplomatic of you, and very professional of you. But I would also like to say that a great deal of the time, that's what we see, that the symptoms do diminish or go away completely.
Yes, and you're absolutely right, and I'm glad that you said that, because I'm not, by saying what I said, I'm not saying that it won't. I'm just saying I don't know, but a lot of my clients have reported to me a decrease in their symptoms in addition to their distress. So absolutely, there is hope, and there are many people, and Sarno talked about it in his book, that they have the book cure.
Yes.
And they read the book and their symptoms are gone and they move on and they never have to, deal with it again. But that's why I said earlier that we're all different in how we respond. So it is absolutely possible.
So you're just starting to touch on the really interesting parts of how trauma affects this process and how it feeds into this process. So if you wouldn't mind sharing, there was a second turning point. So after you read Dr. Sarno's book, you were seeing in better resolution of your symptoms than you had seen from anything else you had done over many, many years. There was a second turning point.
Can I also say, and these were non-invasive?
Oh, yes. Non-invasive, and it cost you $15. Yes.
Exactly.
Yes. Yes. Yes.
Oh, so the other turning point, yes. Before I talk about that, could I just also add that, in addition to these kind of turning points, another factor that really I felt really helped in my recovery, and that is having a supportive and loving relationship with my spouse, my husband. And again, when we start talking about trauma, I think this will make a little bit more sense. But for me personally, having that loving, supportive, accepting person in my life was very healing, and helped to heal some of the effects of my trauma. And so that is a really important factor. So,
and that's why I encourage people, when they come to my channel or when they're learning about dizziness, this should be a collaborative effort with your loved ones and friends as well, your support system. We're pack animals. There's no way around that.
And we're social animals.
Yes.
And social connection is vital. Like we are hardwired to need that. And again, there's evolutionary reasons why, because we were able to survive because we were in groups. People who were on their own way back in prehistoric times, they didn't survive, or their chances of survival were a lot less. So there was safety in numbers. There was safety in belonging to a community, to a group.
Yeah.
And so, so that's a really, really important point, is that it's really important to develop and maintain a good support system, and to rely on it when you need it. You know?
Yep.
But that's, not everybody has that, luxury of having that support system, or that, loving, supportive person. But we all can, we all can learn to do that. It's something we can work on. So, can you remind me the question that you had asked?
I gotcha. So the second turning point.
Oh, the second turning point.
Yeah, the second turning point, because this is where things get really interesting.
Okay.
Yeah.
Yes, thank you for reminding me that. So, so September 2015, Sarno, I learned about that. Everything was a lot better. And then again, slowly over time, symptoms started to creep back. And after a while, I realized that some of the conditions that had contributed to and allowed me to develop these chronic pain conditions, the Mindbody, whatever, those conditions were still there. I hadn't changed some of those conditions, and so I was continuing to create the symptoms, not knowingly, but that's what was going on. And so what I eventually, so this is what happened. So of course, I was seeing therapists at the time to work on my trauma and my self-defense behaviors, my perfectionism, my inner bully, and all that stuff. And it was helpful to a point, but and again, they were well-meaning, but they didn't know about Sarno and TMS and Mindbody, and so they didn't have that knowledge and that experience. And also, there are a lot of different therapeutic techniques that focus more on the body. We call somatic somatic therapies, and cognitive behavioral therapy, CBT, which is probably the most common and most people have heard of it, treatment is not the most effective for trauma.
Thank you for saying that, because I've come out. I mean, I don't feel like I'm in the right position to be an authority on types of mental health counseling or therapy, but CBT is often the treatment that's prescribed for people who have chronic dizziness. And oh yes, and I'm glad that there is some focus on people's mental health, but it really doesn't address the root cause. That's the problem.
100%.
Yeah.
100%. It's like putting a Band-Aid on it, but it's not, like you said, it's not getting underneath to the root cause.
Yeah.
Anyway, so again, while there was got some benefit from counseling, it wasn't enough. I was still having pain and other issues, the anxiety, depression. But because of what I went through with the chronic pain and what I learned, I decided I wanted to become a therapist so that I could help other people with chronic pain. And so I began that process, and I started to realize that if I was going to work with people with chronic pain, that I needed to also get some training around trauma, because there was a lot of, there seemed to be a lot of connection there. So I decided to get training as a trauma specialist. So I did some training, and in that training, I learned about the ACE study, Adverse Childhood Experiences study, and the results of that study. I also learned about how trauma can, affect us as human beings and impact us in a lot of different ways. And the training, the person who I got the training from, his name is Gentry, and he's one of the top trauma specialists in the country, and he's worked with some of the legends, if you will, in trauma treatment throughout the last few decades. Anyway, so Eric developed this approach to treating trauma that he calls forward-facing trauma therapy. And for me, it changed everything. And it just really opened my eyes. Again, it made perfect sense to me. It helped me to understand myself better and how my trauma affected me and what I could do about it. So that was the second turning point.
And we are going to dig into this some more. So in a little bit, I want to make sure that I keep kind of following your story in kind of this logical order, and then we'll come back to trauma. So, so doing this changed everything. And where are you today in terms of symptoms?
So again, I have not had any chronic back or sciatic pain since I discovered Sarno, Mindbody. So it's been 6.5 years. Now, having said that, does that mean that I never have any pain in my back? No. If I overdo it physically, if I'm working where I have to bend for an hour, it's going to, and plus I'm 59 years old. So there's that too. So yeah, I get a little bit of, aching or whatever, but it's temporary. And there's a good reason why I have a sore back, but again, it doesn't last. And again, we can talk a little bit more about this a little later, but the big difference is in how I respond to pain. That is huge. And that's a big part of healing and recovering from this, is changing how you view it, how you respond to it.
Yes.
So I just wanted to, say that doesn't mean I never have a sore back.
Right. Of course.
We're human beings.
Right. I tell people you don't want to never get dizzy again. Like, your dizziness is your body's way of telling you probably shouldn't do that. Right. So if you do something that you probably shouldn't do, then your body's going to get dizzy, and that's normal and expected.
Absolutely. And that's an excellent point, because in the pain reprocessing therapy, that's what we teach, is that pain is a danger signal, and that pain and dizziness, it's a protective. Pain is protective. That's what it's meant to be. That's the purpose of it, so that we don't further injure ourselves.
Correct. Yeah.
So when we have pain because of something we're doing, our brain is like, stop that, stop doing that.
Yeah.
And rest.
Right. Which is a normal, healthy nervous system response.
Absolutely.
This is a normal, healthy nervous system response.
Absolutely.
So the headaches are gone. The fibromyalgia pain.
Yeah. Everything from the waist up is gone. Like I said, I still have some quote unquote neuropathy pain in my feet. I would say from where it was, when it was at its worst. It's 70% better,
Mm-hmm.
which is huge.
It is huge. So in terms of limitations to your daily activity and being able to walk and being able to be active, go places.
I mean, I do have some limits. Again, I'm a human being.
Right.
And if I'm on my feet for too long, they start to hurt. But again, it's not debilitating.
Mm-hmm.
If I have to push through it, I can push through it. You know, when a pain or other symptoms, again, in my work, you know, I use a scale from 0 to 10.
Mm-hmm.
And if pain is between a 1 and a 3,
Mm-hmm.
I mean, that's pretty manageable.
Yeah. Yeah.
You know, 4 to 6, 4, 5, and 6, it's getting, you know, worse. But 7 to 10, that is when it's, you know, it starts to become debilitating and intolerable.
Mm-hmm.
So, you know, 70% better, you know, generally, like I can feel a little bit right now on my feet, but it's maybe a 1 or a 2.
Mm-hmm.
So again, it's not 100%, but I am able to do pretty much anything I want to do, but I'm not running a marathon.
Mm-hmm.
You know, if I walk for an hour or 2 hours, my feet will be sore, but it's tolerable.
Yeah. So it's you live a normal, fulfilling, happy, satisfying life.
Absolutely.
Yeah. And it's not because you've just learned to live with the pain. The pain is actually immensely diminished.
Correct.
Yeah. So
But what I've changed is how I respond to it.
So I'd love you to talk about that more, and I'm gonna frame it in this question. So you've already given so many little nuggets of advice to people suffering from chronic dizziness. By the way, many of whom also have chronic pain and or chronic digestive issues. So this is a very common thing.
Mm-hmm.
So you've already given so much great advice to them, but it sounds like you're about to give them the best advice that you have given them so far. So there's something really important about how they respond to their symptoms. So would you mind sharing kind of the takeaway here on how changing your response changes the game?
Sure. So you know, the typical, understandable, normal response to pain or dizziness is, oh my God, what's wrong?
Mm-hmm.
Perfectly normal, understandable response.
Oh, perfectly. Yeah.
Yeah. But when we're talking about mind-body pain, dizzy, you know, mind-body symptoms, that becomes chronic, that initial response of fear, like there's something wrong, what's wrong, that becomes a chronic response, is fear.
Mm-hmm.
And whenever we as human beings respond to something with fear, it triggers our threat response, our fight or flight. Because we're telling our brain, because we're responding with fear, communicating to that part of our brain that this is dangerous. And so your brain wants to remember that. Mm-hmm. This is dangerous. So, you know, the symptoms begin, we respond with fear. That triggers our fight or flight. And because we're not able to resolve it, we're not able to, you know, go to a doctor and
fix it
and make it go away. We then start to also become preoccupied with it.
Oh yeah. Oh
and
yeah.
again, very understandable, because pain is a perceived threat.
As is dizziness. Yeah.
As is dizziness. It's a perceived threat.
Mm-hmm.
And so it wants our attention.
Mm-hmm.
You know, we need to pay attention to this so we can fix it, make it go away. So then what happens is you typically fall into this pain, fear / preoccupation cycle. And what happens is the fear and the preoccupation will make it worse, and it will prolong it.
Mm-hmm.
But again, I didn't realize that that's what I was doing.
So do you think that the first step is just realizing you're doing this?
Well, the first step has to be that you believe and accept that this is what's causing your pain, that there is nothing wrong with your body.
Mm-hmm.
So there isn't anything to be afraid of. This is your brain causing the pain, causing the symptoms. And we haven't really kind of gotten into why the brain will do that. But if you can accept and believe that there's nothing physically wrong with you, then that can help to reduce the fear.
Mm-hmm. Yeah. Yep. Yep.
So that's what I'm sorry.
So that understanding is a really, really big piece, the education part. I mean, that's what Dr. Sarno talks about. He said the treatment for this condition is education. That is the medical treatment for it. That's what he said something like that.
Yes, you're right. He did. But as we said earlier, sometimes that for some people that's enough, for some people it isn't.
Right.
But it has to be the first thing.
Precursor. Yeah.
Yes.
So, okay. So do you have any practical advice for people who are in this process of, they've kind of come through this acceptance a little bit. They've watched other videos on my channel. They've read some books. They've done the course. So what can they do then to start arresting this cycle of fear?
So if they have, done the reading, watched the videos or whatever, because there are, Dr. Schubiner has some videos too.
Mm-hmm. There's some great videos out there. Yeah.
Really good videos about why the brain or how the brain does this. Mm-hmm. And that can be helpful as understanding, because why would my brain cause pain? Like, it doesn't make sense that the brain is trying to protect me and is trying to help me.
Right.
So yeah, doing the education part, and if they've done that and they're still having symptoms, or maybe it's diminished a little, but not enough, they're still suffering, then they should probably see somebody who's trained to help them walk through the other steps or through the rest of the process. Mm-hmm. But also, again, we haven't talked a lot about the trauma. So if there is trauma, that's a whole nother piece that might need to be addressed.
Yes. So just to recap, you're saying that acceptance and education part is huge. And for many people, that's going to result in diminishing symptoms. And if it is, then keep going. Mm-hmm. And if it isn't, then it's time to reflect on what else might be going on that could be, potentially fueling some of this nervous system activation, which I talk about a ton on my channel. So if people have watched my channel regularly, they're going to be very familiar with this concept. Okay. So one thing that I don't talk about on my channel a lot is trauma specifically, because that's a little bit outside my area of expertise, and that's yours. So I'm really excited to start asking you some questions about trauma specifically.
Okay.
So can you, this is such a big question, but why do so many people with chronic dizziness, chronic pain, and other unexplained conditions have a history of trauma?
Because trauma affects the developing mind and body of a human being, a child, in many different ways, neurologically, hormonally, and endocrinology. I don't think I pronounced that the right way, but
that's fine. Neither of us are gonna, yeah.
Yeah, but it can affect all of our different systems in our bodies, and including the nervous system, neurologically.
So it affects these different symptoms. And is it a requirement when we talk about trauma? Are we talking specifically about things that we think of as traumatic, like awful things, or are we talking about do other things kind of fall in that category that people might not be thinking about?
Yeah. So what is trauma?
What is trauma? Yeah. Yeah. What is trauma?
So I'm trying to decide whether to cut to the chase but I think I'll cut to the chase. Trauma is any physical or emotional experience that is painful.
Okay. And so you're saying any painful emotional or physical experience could potentially affect the nervous system?
I'm saying does.
Yes. So any physical or emotional hardship or pain affects the nervous system. So what differentiates a situation that permanently puts a nervous system in a position to develop symptoms like chronic pain and chronic dizziness versus a nervous system that doesn't go that far?
Yeah. So now let me kind of fill in, kind of backfill a little bit.
Okay.
Trauma, what trauma is. So like I said, it's any physical or emotional experience that is painful. There are other factors that come into play that can determine how much impact or how much of an effect it has on us as a human being, and our nervous system. Number one is actually, let me say one thing first. When there are different types of trauma, and I think when most people hear the word trauma, they typically think of the big ones, what we call big T trauma. But there is also little t trauma. And I think that, I hesitate to say all human beings, but I'm pretty sure all human beings have experienced some trauma. Little t, maybe not big T, but at least little t. If you've gone through middle school, you've had trauma. We've all had it.
I was just about to ask, what's the definition of being like mildly bullied or having parents who were kind of inattentive to your needs, but not full on neglect? Like, so you're saying those things count as traumas that could affect the nervous system, or that do affect the nervous system.
Yeah. If it's emotionally painful, which I would assume those things were, that's trauma.
Yeah.
So there's big T, there's little t, there's single incident trauma where it was a one-time thing, and then there's chronic trauma. And so, but the thing is, so even though there are different types of trauma, they all have the same thing in common. And what that is when we are exposed to or experience trauma, it causes us to view the world as a more dangerous place.
Yes. So now we're starting to tie it back together to that nervous system.
Yes.
That might interpret things as threats.
Correct. Yeah. So, the world is a more dangerous place because of this painful experience that we had. which means that I feel less safe. So again, as a as a human species with a survival instinct, if I don't feel safe, what is my physiology? How is my physiology going to respond, or how am I going to respond physiologically? If I'm not safe, that means there's danger, there's threat in my environment, and I need to get to safety. I need to feel safe. So, so when that happens and we perceive the world to be more dangerous and we feel less safe, we need to, and I haven't specifically said this yet, but I think this is more relevant to childhood trauma. Not that trauma in adulthood is not horrible, it is, but in terms of how it affects us physiologically, I think the effects can be more significant when we're exposed to trauma as a child, because our brains and our bodies are still growing and developing, and because we haven't developed the skills to cope with it, to process it, to understand it and make sense of it. So I'm not discounting trauma as an adult, but I think this is more relevant for childhood trauma.
And I want to kind of tie this in to something that I've talked about recently, that childhood trauma, whether capital T or little t, sets up the adult brain for being more vigilant or more apt to see threat, right?
Yes.
So even if you have gone to therapy and dealt with your trauma, your nervous system could still be wired to be extra vigilant. And that means you're more likely to be triggered by or to have responses to situations in your current life. Is that accurate?
Yes, it is. And you read my mind.
Oh, fantastic.
So going back to, childhood and trauma and, the world perceiving the world as more dangerous and I'm less safe. As a child, we have to figure out how to adapt to this new reality, this more dangerous world, so that we can survive. And the way that we do that is by becoming hypervigilant to threat. So we become, just like a soldier in battle, they become hypervigilant so that they can see the danger or the threat coming, so that they can, prevent, that they can shoot first. So it's the same physiological response, that hypervigilance to threat. So we become more hypervigilant to threat. Now we're kind of on guard. We're kind of, scanning our environment, always being on the lookout for potential danger and threat. Well, what happens when we become more hypervigilant to threat is that we begin to perceive more threat, because again, we're perceiving the world as a more dangerous place, and people are a big part of that. And so, our interactions with other people, we start to, perceive that this person might have, intentions to hurt us or harm us when maybe they don't.
And this isn't always conscious, right?
Oh, no, absolutely not.
So this is on the way out of our conscious awareness. This is a nervous system response.
Absolutely. It's a nervous system response. And again, as a way to adapt and survive.
So people might not think sometimes, oh, my relationship with my wife or my, boss might be triggering me because there's no obvious relationship, but it could, what you're saying is it could, your nervous system might be seeing it the same way or might be responding to it in an abnormally vigilant way.
Absolutely. Because what happens to a child that's exposed to trauma, and again, the younger they are when the trauma begins, the more impact it has. The longer that the trauma persists, there is chronic trauma, emotional, physical abuse that goes on, sexual abuse that goes on for years and years and years. So the younger the child is, the longer the trauma continues. And another important factor in determining how much it affects us is whether or not we have a supportive adult that can act as a buffer for the child, between the child and the trauma. So if a child does not have a supportive adult that can act as a buffer and then also help the child to feel safer and make sense of or process their emotions, because they're going to be having emotions,
right? And
they need to be taught and learn how to identify them, how to express them, how to regulate them so that they don't get overwhelmed by their emotions. And if they don't have somebody to do that,
this is such an important point, because I talk about emotions a lot as well. And what you said, you use the word processing those emotions and regulating. So the tools that we have as a child with a developing nervous system are not the same as the ones we have as an adult. And if those traumas go unprocessed and our nervous systems are unregulated, again, whether that's little t trauma or big T trauma, we end up with a nervous system that is not optimally calibrated. Is that right?
Yeah, it's dysregulated. So that's the progression, the hypervigilance, to threat, the chronic perceiving threat, chronically perceiving threat in your environment. When we perceive threat, like I said earlier, it triggers our threat response, which is the same thing as our stress response, which is the same thing as our fight or flight. It's all the same thing. So whether it's actual danger or perceived danger, the response is the same. That part of our brain can't distinguish between actual threat and a perceived threat.
And I want to mention here, just for my viewers, many of you are young adults. The brain is still highly plastic. So your nervous system is still highly plastic. It's still developing until your mid-20s. So now, David, you've said, as when someone's younger, it could have a more potentially catastrophic impact. But we don't want to downplay either. Even things happening in early adulthood may not be properly processed and regulated.
Well, absolutely. So when I talk about childhood trauma, that's up to the age of 18. But what you're talking about, 18 to 25, and it still can have an impact on the development of their brain and their nervous system. But especially if they did have trauma before the age of 18, it's gonna impact them even more.
So again, many of the people watching this video have, actually, if we go back to how we defined trauma, I would say all of us have some level of trauma, but some of us had more regulation and some of us had less. So what I tend to see in my clinical work is that most of the people I see have more than one instance of trauma. And then there is also frequently the lack of a stable, safe adult figure in early childhood, or that maybe one parent is a little bit inconsistent, or maybe not a little bit inconsistent, very inconsistent or unsafe, and the other parent is. But even in the world of chronic dizziness, we see exactly the same pattern. And then, of course, the more trauma someone has, the more likely they seem to be to develop these kinds of chronic symptoms. And that's what you were talking about. You mentioned that people with adverse childhood experiences are much more likely to develop these kinds of chronic conditions.
Yeah, that the risk is greater.
Right.
And you just referred to the adverse childhood experiences and ACE, and that came out of a pretty major landmark study in the 1990s. And they developed a list of what they call it, ACE Questionnaire, with a list of 10 adverse childhood experiences that somebody could be exposed to. But again, they're more of the big T trauma, so it doesn't capture all.
Sorry, my lights keep flickering. I'll turn it off if it keeps doing that. Just maybe it's just emphasizing what you're saying here.
I thought maybe there was a fly or something.
No, it's just the lights flickering for some unknown reason. I'm gonna shut it off just 1 second. Be right back, guys.
Yep.
I guess the electric company is really into this conversation, so it's emphasizing it.
Yes. So the ACE study, ACE Questionnaire, I use that as a screening tool for all of my clients. But the study basically showed what's referred to, or what they refer to as, a very strong dose response relationship between adverse childhood experiences and the increase in the risk of developing all kinds of chronic physical, mental health, and behavioral conditions, including chronic pain. And why that is significant is because a lot of studies, if they can determine just that there's a correlation between two different things, like that is pretty big.
Right.
But a dose response relationship means it's not just correlated. It means for every additional ACE, or adverse childhood experience, the risk increases. Like you can measure. It's a measurable increase. Absolutely. Right. So this isn't like these two things are related, but we don't really know how. This is implying a causative relationship. Right. It's implying a causative relationship. Right. So an ACE score can be from 0 to 10. And I will link to an ACE questionnaire here in the description. So if you'd like to look at that, I'll have that there. There's all kinds of really good information out there on the ACE study, and again, showing how much increased risk there is, like a score of 4 or higher. The increased risk in suicide is 1,500%. With an ACE score of 4 or higher. Yeah. Cardiovascular disease, certain kinds of cancers. It's pretty eye-opening. Right. And this lends even more credence to this idea that we're talking about, that it has profound physiologic effects. It has profound effects on the body. Absolutely. And so what we're talking about here, to give a takeaway, is that for people who have higher ACE scores, again, 4 or higher is is shown to be a really strong relationship. Is that I'm sorry, I lost my train of thought there.
So you're saying ACE scores of higher than 4 are indicative of a higher risk.
Yes.
So for those people, you were going to make a suggestion about like what they could do, or a suggestion for how they may want to address their chronic pain or chronic dizziness.
Yeah, actually, I think what I was going to talk about was that what it really comes down to is, as you said, how it is affecting us physiologically, and what that the primary physiological effect is that it causes our autonomic nervous system to become dysregulated.
Yeah,
that is the takeaway here, and so. What happens, and there's a lot of, there's a ton of research out there showing the relationship between childhood trauma and chronic pain, not just the ACE study. So for people who have had higher ACE scores and are perceiving threat chronically, are chronically in their fight or flight, in their autonomic nervous system, that's when we get symptoms. It's because we are meant to be in our parasympathetic nervous system. That's how we're designed, to be in our parasympathetic most of the time.
And that's our rest, relax state, or rest, digest, relax state.
Absolutely. Yeah. And we're only meant to go into sympathetic when there is an actual threat or danger that we need to respond to fight or flee. Or we need, we're in kind of a high demand situation and we need just a little bit more energy, a little bit more adrenaline to perform. But those are meant to be temporary, short term, and then get back into parasympathetic. People who have high ACE scores are chronically in their sympathetic nervous system. And that is our chronically constricted muscles. When we're in fight or flight, to prepare us to fight or flee, the brain communicates to the body and tells us to constrict our muscles. So for a lot of people with chronic pain, their muscles are chronically constricted. Then you have the stress hormones that are chronically being released and going through the body and causing damage to tissue. There's research showing that excess cortisol in the body can actually damage the myelin sheath around the nerves. And that can cause all kinds of neurological symptoms, including idiopathic peripheral neuropathy and other weird symptoms.
So to put that in simple terms for you guys, so cortisol is a hormone that is actually released in a daily rhythm normally in our bodies. It helps increase our arousal, meaning our energy levels. So normally you get a bump in it in the morning, and then it's supposed to drop down and kind of hit this nice low level so your sleep hormones can kick in. So when this hormone is dysregulated, it's chronically elevated. It causes some of these problems that you mentioned, David. And the myelin sheath is like an insulation on your nerves, connection points. So your nerves work like electrical wires, and insulation, the myelin sheath, serves as insulation on those wires, which helps the signals travel faster. So if that myelin sheath is degraded, electrical signals are going to get mixed up.
Thank you for
I'm the mechanism girl, what can I say? Right. So no, but these are really good points. So now, okay, so we've talked a lot about how horrible trauma is. And if anyone's listening to this and is not yet convinced that trauma is a very big risk factor for chronic pain and dizziness, then that person should rewind and listen to it again, because I think it's very clear, it's definitive. So my question is,
Hey, Yonit, could I just
go ahead.
add to, if your listeners are interested in learning more, educating themselves about the impact of ACEs, there is a TED Talk on YouTube by Dr. Nadine Burke-Harris.
I will link to that also in the description. I'm going to have to go back and listen to this whole interview and remember all the things I promised to link to, but I will link to that talk as well.
Yeah.
I have the link for it.
Yeah. So she did an excellent TED Talk, and she also wrote a book called The Deepest Well, where she really gets into how much it affects us physiologically, but also down to the DNA level, how trauma
can affect us.
Yeah.
So what can we do about this? Is this a death sentence? I mean, does this mean someone's sentenced to a life of chronic pain and dizziness and cardiovascular problems?
Absolutely not. And again, to disclose, I have an ACE score of 9 out of 10. So I'm living proof that there is hope, there is healing. Is it easy? No, but it's absolutely worth it. And anybody can heal. Anybody. I believe that our bodies have a natural healing and repair ability and function, but that only happens when we're in our parasympathetic. When we're in our sympathetic too much, that natural healing and repair isn't functioning.
It's compromised.
It's compromised.
So what I'm hearing is there's hope. So that's good. That's good to know. And it sounds like the key has something to do with the nervous system.
It does. So the key is, because remember, all trauma has one thing in common, is that it makes us feel less safe. And that's what leads to our nervous system becoming dysregulated. So the answer is to feel safe, meaning beginning to recognize that we are 100% safe in the moment. If that's true, if somebody is in a situation where they're not physically safe, there is actual physical threat and danger, they're not going to be able to feel safe because they're not safe. So for people in that kind of a situation, they need to get to safety first. And then, we don't really have the time to get into that, but for people who there are no actual physical danger or threat in their environment. It's about beginning to recognize that there is no actual threat or danger, that I am 100% completely safe in this moment. And that is the only time that we can ever say that we are 100% completely safe. We can't say that tomorrow for next week, because we don't know. There are potential dangers out there in the world. We all have to live with that. But if they're not actual danger in the present moment, we can begin to recognize that we are safe, number one, and then do something to get out of our threat response, out of our fight or flight, and out of our sympathetic nervous system back into parasympathetic. In other words, learn to interrupt our threat response by, one, recognizing that I'm safe in this moment, and two, by acutely relaxing all of the muscles of my body, because it is not physiologically possible to be in our fight or flight, our stress response, in a body whose muscles are completely relaxed. It's not possible.
So I'm gonna emphasize this. So first of all, I just want you to know I feel very vindicated right now, because on my channel I talk constantly about parasympathetic breathing, which is just another method. But parasympathetic breathing takes some skill. It takes some practice. You have to sit down, or not necessarily sit down, but you have to do it for a few seconds. So what you're saying is you could just consciously relax the muscles of your body, take that tension out, and that sends that signal to your nervous system that it can come out of sympathetic mode.
Yes, but you have to recognize that you're safe. So
that's a prerequisite. Okay.
You have to do both. So the cognitive piece is recognizing that you're safe, that there is no danger, there is no threat. And the somatic, the body part, so the mind body, I am safe, and then acutely relaxing all the muscles of your body, especially the muscles of the pelvic floor.
Yep. Yes. So that's originally how I came up with this term I call parasympathetic breathing, because I went down a rabbit hole myself for reasons I'm not going to even get into right now, related to some of my own TMS or mind body symptoms. But pelvic floor tightness is directly related to sympathetic arousal. So if you've been diagnosed with pelvic pain, or not pelvic pain, just pelvic tightness, it is very likely that there is also some nervous system hyperarousal going on as well.
Yep, absolutely. And the reason why it's so important to relax the muscles of your pelvic floor in addition to the rest of your body is because the vagus nerve, which is the longest cranial nerve in our body, and it runs from the base of our brain all the way down to our pelvic floor. And when we go into fight or flight, into sympathetic, the brain communicates to the body to prepare to fight or flee, and it communicates to the body through the vagus nerve. And so if the muscles of the pelvic floor are constricted, it's basically sending a message back to the threat response system, I'm not safe. So if you're not able to relax those muscles, you will be sending a message back to your brain, I'm not safe, I need to stay in fight or flight. And then the brain's like, oh, I'm not safe. All of the muscles of my body constrict again. So you kind of get stuck in that feedback loop.
Yeah. And what I found is this isn't always so easy to teach people.
It's not. And especially for people who have had sexual abuse. Or some kind of, sexual violence.
But you're saying anyone can learn. It can be learned.
Yes. Yeah. And so I do want to say too that what I just described is one way of invoking the relaxation response. Eric calls it the wet noodle, where you just go, he calls it the wet noodle. That is one way to interrupt the threat response and invoke the relaxation response. There are other ways of doing that as well. Eric's book,
Forward-Facing Freedom, which I will also link to below.
Forward-Facing Freedom. Yeah. So there are other exercises. The reason why he prefers and I prefer the wet noodle is because you're able to engage that skill and still remain engaged in what you're doing because it's all internal. Nobody has to know what's going on inside your brain and your body. The other exercises, you kind of have to disengage and go off for a few minutes in a quiet room.
Right. Like the parasympathetic breathing it's like there's a process, there's a close the eyes and relax, which is great, but not feasible when you're standing and talking to your boss.
Exactly. Right? Exactly. And again, for people who have a lot of trauma, who are perceiving a lot of threat throughout their day, they're perceiving threat constantly, interacting with people at work. And so again, it's not feasible to, can you wait, I need to go and regulate my autonomic nervous system.
Yeah, hang on, I gotta go regulate. Be right back.
Yeah.
She needs to go to the bathroom. Like, what is she saying? Right?
Yeah. So that's it. I mean, and again, for people with high ACE scores with a lot of trauma, again, that is simple, but it's not easy. Because they have years and years and years of past painful learning and conditioning. And then when you talked earlier about triggers, they have a lot of triggers that are reminding that part of their brain of past trauma. And what happens is when our fight or flight is triggered is our thinking brain, our prefrontal cortex takes a back seat, and we actually become cognitively impaired, almost like a minor traumatic brain injury. So we lose access to all of that higher functioning stuff. I lost my train of thought again.
So you were saying that when the sympathetic nervous system comes online, the thinking brain goes offline. And this means that people with trauma, even when they know, hey, I'm just being triggered, they have a much harder time paying attention and knowing when this is happening, because that part of the brain's already offline.
Yes, thank you. And again, that, and then also what I want to say too is that when we go into fight or flight, we lose access to the thinking brain. But then what happens is we engage what I said earlier as self-defense behaviors. Because
so interesting. So I had not thought of that. Yeah, so please continue.
So we engage the self-defense behaviors that we learned when we were younger.
Like people pleasing, perfectionism, that kind of stuff. That can stem from that nervous system response.
Absolutely.
Interesting.
Because remember, as a child, we had to figure out how to adapt. How to survive and how to feel safer. And so we developed these self-defense behaviors back then that helped us to feel more safe. And so they worked then. They helped us to survive. But now that we're an adult and we're not in that environment anymore, and we have the skills and the capacity to take care of ourselves and protect ourselves, which we didn't have back then, those self-defense behaviors are no longer helpful. They were then, but they're not now. So we engage these self-defense behaviors in the present when something happens in the environment, a trigger that reminds that part of our brain of a past painful experience. We may not even be aware of what that is. It's usually, it's a sensory data. So a sight, a sound, a smell can trigger,
or an emotion. Could an emotion do the same?
I don't know if the emotion, it's hard to say if the emotion triggers it or if the emotion follows the trigger. I'm not 100% sure on that, but we can definitely learn to be afraid of and avoid emotions, which then again, when we avoid something, we're telling our brain this is dangerous. And so anytime that emotion does come up, it's going to trigger our fight or flight, because we've taught our brain that this emotion isn't safe, it's dangerous.
Right. And that can be the result of trauma, capital T or little t trauma, if a certain emotion wasn't safe as a child for whatever reason, say due to a parent or other difficult situation. A certain emotion could potentially become a trigger for someone. Like I've had people tell me, I don't get angry. I just never get angry. So would that be a red flag for you if someone walked into your office and said, I don't really feel angry?
Yeah. Yes. In a nutshell, yes.
In a nutshell, yes. So, gosh, what great material you've given people to work with here. So just this idea that people who've had trauma, the takeaways being that this has affected their nervous system, but you can learn to re-regulate your nervous system by reminding yourself that you're safe and using physical methods to take yourself out of fight or flight mode. That's incredibly empowering.
Absolutely. 100%.
So it sounds though like another piece has to be dealing with trauma that hasn't been dealt with, right?
Well, with not really. With forward-facing trauma therapy, you know, we don't have to go back, unless somebody wants to go back and talk about it. But as a therapist, if they were my client, I would encourage them to wait to talk about past trauma until they've learned how to regulate their autonomic nervous system.
So that comes first.
That comes first, because if they haven't learned that, they can re-traumatize themselves,
right,
and also strengthen the conditioned response. Because every time we experience trauma, we're going to have a conditioned response, which is how we learn to respond, growing up. And so every time you do that, you're strengthening the conditioning, you're strengthening the neural pathways in the brain. This is where all that neural circuit and neuroplastic terminology comes from, because that's how we learn, is by developing neural pathways.
So the idea would be, if someone wants to go back or feels it's necessary to go back to reprocess the trauma in whatever way makes sense, they need to be able to do that in a relaxed body. That's what you're saying.
100%. Absolutely.
Yeah.
The only other time you might need to go back is if the person is having what's called intrusive symptoms in the present, meaning flashbacks and nightmares about past trauma. Then you have to deal with that. But if the person is not having significant intrusive symptoms in the present and they have no desire to talk about their past trauma, you don't need to talk about it to heal.
Yeah. That is such an interesting approach. And it kind of lines up with a lot of things that I talk about on this channel when I say just recognizing, we talk about emotions, as I said, less about trauma, more just about emotions, but just recognizing that there's an emotion there in many cases, and it disarms some of this fight or flight. So just recognizing I'm being triggered, my nervous system here is being triggered. And knowing how to take your nervous system out of that response, that can disarm it in a very effective way that doesn't require you going back and fixing something.
Yes. When we're talking about triggers, again, what we're talking about is sensory. And so some triggers are going to be stronger than others. And how we help people to how we work with people and triggers is, it's about helping them to confront a trigger as a perceived threat.
Yes.
That's what it is. And again, it's reminding that part of your brain of some past painful experience, and the brain is like, danger, 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 self-defense, self-defense.
Yeah.
And so it's learning to recognize that. And if you are 100% completely safe in this moment, do you need self-defense?
Right.
No, you don't. But the issue is the conditioning. And so it's about helping people to desensitize themselves to the triggers by confronting their perceived threats in a relaxed body. And every time you can do that, you are lessening that conditioning and you're lessening the intensity of the trigger. Every time you do that. Every time you do the opposite, when you confront a perceived threat and you are not able to relax, you're strengthening the condition.
Yeah. So this is something I talk about in relation to vestibular rehabilitation therapy, which is a type of therapy many of my viewers have done because it's supposed to be for everyone who has dizziness, which is also not correct. But the idea there, to some extent, is exposure therapy. But there's a way to do it. And that's what I preach on my channel. I don't really care which exercises you're doing as much as I care that you're doing this while you're regulating yourself.
Yeah. Well, I'm glad you said that because that's exactly what this is exposure therapy. But it has to be done the right way with the help of a trained professional, because if you're not, able to get relaxed and stay relaxed in the context of a trigger or a perceived threat, it's re-traumatizing and it's strengthening that conditioning. So.
And I want to just make one note here because I know my viewers, I know a few of them personally. And one of the things that they'll worry about when they hear you say that is, what if I'm doing it wrong? What if I'm re-traumatizing myself all the time by getting exposed to the things that make me dizzy? So it doesn't sound like that's what you're saying, because what you're talking about are exposing yourself to triggers to trauma, right? So
trauma triggers,
but things like exposing themselves to the things that make them dizzy, that's not the same thing. That exposing yourself to those things is something different.
You're absolutely right. And thank you for clarifying that.
I just know my people. So you guys, that has been clarified. So you can continue to expose yourself to the things that trigger your dizziness. You're going to be okay.
Yes. When I talk about triggers, I'm talking about things that trigger your fight or flight, trigger your threat response.
Right. From related to
because of past trauma.
Yes.
But when you're talking about chronic mind-body pain or dizziness, yes, you do need to do exposure to the quote-unquote triggers that you have come to believe certain things trigger my pain or trigger my dizziness.
Yes.
You've made an association that when I do this, I'm going to have pain, or when I do this, I'm going to have dizziness. Those things you do need to do exposure with.
Yes.
But also it is important to, I believe,
to do the best you can.
Well, do the best you can, but you also you do have to pair it with relaxation.
Right.
Because if you're trying to do it using just brute force and white knuckling your way, confronting these triggers, and your symptoms are increasing significantly, like I said, 7 out of 10 or higher. Right. You don't want to do exposure.
Then you want to bring it back down.
Right.
Bring it back down.
Yes.
And what I'm just clarifying this in one more way for a certain subset of my viewers who I know have constant symptoms. So what you're talking about is exactly the approach that I recommend. If you trigger your symptoms, you want to take time to regulate yourself, bring your body back down out of that sympathetic mode. But I have some clients and other viewers who have 24/7 constant symptoms. And so in those cases, it has seemed to be beneficial for them to try to have their worlds as open as they can make them while they're working on the other stuff. So would you agree with that approach for them?
What do you mean by having their world open?
Trying to not avoid things. Yes, trying to avoid avoidance, but trying to get outside, try to take a walk, try to get out to socialize in small groups or one-on-one, just trying not to let their lives shrink down so that they're stuck at home.
Yes, I agree. That is important. But again, I think it's also important that they do it to the level that they are able to tolerate.
Yes.
And
yes.
what I tell my clients we don't start with exposure.
Oh, of course. Yeah.
Yes, we start with the education, and then again, when it comes to this PPD or mind body pain, and my clients, we work on strengthening their belief and their acceptance that this is what is the actual cause by helping, by gathering evidence, looking for exceptions. So we do that work first before the exposure. And then with the exposure, I tell them only do exposure when your symptoms are a 6 or less out of 10. If it's a 7 or 10, 7 out of 10 or higher, do not do exposure. Do what I call avoidance behavior.
Okay.
So when it's severe, you do want to do avoidance behavior. You don't want to confront the triggers then. You want to do it when the symptoms are a little bit low.
Because otherwise you could potentially reinforce that association. That's what you're saying. Yeah. It can get just tricky sometimes with patients who have like constant symptoms that don't change.
Right, but are their symptoms constantly a 7 out of 10 or higher?
I've had some report that, but the thing is, there's no clear association between the things they're doing and the symptoms. So they could be at home and at a 7, or they could go to a cafe and be at a 7. So it's not changing based on their location. That happens to some of them.
Yeah, I mean, if somebody is reporting that they're a 7 out of 10 or higher 24/7, it's hard to do exposure.
Yeah, it is. Yeah. It is. I have a few. Thankfully, most of you guys watching don't fall into that category, but I know I have a few here who do. So, okay. So I know that we have talked for a long time and we've given people a lot to digest, but I want to ask a question that I'm sure is at top of mind for people watching this. So if someone has trauma, whether capital T or little t, and says, oh gosh, this is something I need some help with this. And or maybe just someone who has chronic pain or chronic dizziness and just feels that they need help. So what should they look for in a mental health professional? What should they look for? Is there a specific type of credentials or qualities? Like, how do they know that this person is going to be able to help them with mind-body syndrome and trauma?
Great question.
Yeah.
I wish I could be more positive about this, but unfortunately, I think that they are a bit few and far between, especially people who, are trained in both trauma and mind body. Like you might find trauma, somebody who can do the trauma, somebody who can do the mind body. And if you can't find somebody who has both, then, maybe you might need to do it that way. I would recommend personally starting with the trauma. If you do the ACE questionnaire, if you have an ACE score 4 or higher, and you feel like your symptoms could be related to your trauma, I would recommend working on the trauma first. If you can't find somebody who can do both. Right. Number one. So, and the thing with the trauma piece too is, again, I'm a little partial to the forward-facing approach, because in my personal experience and as a therapist, and Eric has said this too, that I believe that it's a more gentle. You get some got some
mowers going on. I'm going to mute my mic while you're talking.
I believe that forward-facing trauma therapy is a more gentle and more a more accelerated approach to treating trauma. Some of the old school trauma therapy can be re-traumatizing. So I'm partial to forward-facing, but I'm sure there are a lot of really good trauma therapists out there that have a different approach, but that's just my personal preference.
So you're saying though that a lot of trauma therapists aren't going to be versed in mind-body stuff at all?
Correct. Again, unfortunately. So as far as the mind-body work, I would recommend that people go to the PPDA website. They have a list of providers there, and then also Pain Reprocessing Therapy has a website with a list of providers there who are trained and certified in pain reprocessing. So those are two places that I would recommend that they go, and if they're looking for somebody who's trained in mind-body. The pain reprocessing therapy is relatively new. That just came out last year. So there may not be a lot of people who are certified in that, where people are located. But hopefully as time goes on, more and more people will become certified in that. So beyond those credentials, what I would recommend people do when they're looking for a therapist is to focus on how they feel when they talk to the therapist. So I would recommend you talk to them on the phone. Most, if not all, therapists will do a 15, 20, 30-minute free consult and talk to them and see how they make you feel. And, the research shows that the number one factor that determines whether somebody has a positive outcome in therapy is the therapeutic relationship. So if the therapeutic, relationship isn't working, it's not a good fit for an individual, then it doesn't matter what training or what modalities or techniques they're going to use. It's probably not going to be as helpful for you. So the fit and that relationship is key. And, if you feel heard and understood and respected by this person when you talk to them, that's usually a good sign. So
I tell people, because I send people to therapy all the time. Therapists are like shoes. Sometimes you have to try on a few.
Absolutely. Absolutely.
Yeah.
I'm not everybody's cup of tea. So I'm not a good fit for everybody, and that's okay.
Right. Nor am I. Right.
Yes.
Exactly.
Yeah.
But if this approach appeals to you, if this makes sense to you, and you're seeing yourself in my channel or in the books that you've read or any of these other resources that I'm linking to that talk about mind-body syndrome, then there are providers who are mind-body specific who can help you, especially if you have done some work with your trauma.
Yes.
And I've seen that myself in my clinical practice. And I tell people, obviously I can't guarantee any timeline either, but it's remarkable to me that the people who I see who get better the fastest tend to be the people who've already done a lot of that work before they ever see me. So yes, I have a high ACE score. I've gone through years of therapy. I've worked through a lot of this. Now the final piece is just connecting that idea of the nervous system and the hypervigilance causing or creating some of these physical symptoms. And that's not as big of a leap as just even starting to dig into the fact that trauma could even have any relationship with this.
Right. And, the pain can be caused by a number of different factors. So, it's usually not just one thing. There's no magic pill, so, my advice would be, don't give up. Be persistent. There is definitely, hope. There is help. So don't give up, and just keep looking for that right fit for you.
And on that note, David, are you are you going to have another group, a pain reprocessing therapy plus trauma group soon that people could
Yes.
join if they were interested in it?
Yes, absolutely. I don't have a specific date yet, but more than likely it's going to be mid-April to late April.
And where could they find information about that?
They can contact me, visit my website. I haven't
which I will link to.
Yeah. I haven't put information on my website about the group yet. Again, this is a fairly new group because, like I said, pain reprocessing just came out last year. But they can reach out to me, and I can let them know when I'm ready to start another group.
And just so we're clear, pain reprocessing therapy, although it's designed with chronic pain in mind, many of these principles are going to apply to you if you have chronic dizziness as well. So if this is something you're interested in, then this is a viable option for you, being part of a group like this that goes through a systematic approach like PRT or pain reprocessing therapy, especially if you also have had trauma. Working with someone like David is going to be really helpful to you. Yeah. Well, thank you.
You're welcome.
Thank you so much. This is just, my eyes are spinning just thinking about all the things that we talked about. So I feel like people who watch this are going to need to watch this a couple times to get everything out of it that we talked about.
Yeah, I know there was a lot of information, but just go back and rewatch it. And I think I also, just another link. Eric Gentry has 2 videos, has a bunch of videos on YouTube, but two that deal specifically with autonomic nervous system and regulating all that. And so if people are interested in watching those videos, they're free and they're on YouTube. So
yes, and I'll link to those as well. And they're specifically, he talks a lot about compassion fatigue. And I've got lots of nurses and teachers who watch this channel, I got to tell you. So you are a nurse or teacher and you are suffering from chronic dizziness, these videos are worth watching for sure. And they're worth watching for anyone, but especially for you.
Absolutely. Yeah. He's developed a whole program around compassion fatigue.
Yeah. And I've seen every video of it, so I can tell you, yes, it's really good. It's really good.
Right.
So, okay, so I'm going to end the recording. We could stay and chat for a minute, but guys, thank you so much for tuning in. And questions, comments, drop them below. If you liked this video, please share, subscribe, and let all your friends know that this was a great video. All right, I'll talk to you soon. Bye.
Bye-bye.